Welcome everybody. My name is Amanda Wood. I'll be running the webinar today on understanding autism. As I just said, for those of you coming in, the chat line is there. Please feel free to type your questions into the chat line and I will do my very best to answer them all tonight while we're online. So my name is Amanda Wood. I'm the CEO, psychologist, and I'm also a behaviour support practitioner with Real Therapy Solutions. My entire career has been supporting people with autism and or a disability. So for the last 25 years, I've worked in the disability autism sector. I cannot see myself leaving that sector. I love it. It's something I'm very passionate about. I have a master's degree in psychology and now I'm the CEO and owner and principal psychologist at Real Therapy Solutions. So we are a multidisciplinary therapy service. We've been around long before the National Disability Insurance Scheme, providing therapy and behaviour intervention and support to people with disabilities across New South Wales. We actually work across Australia now. We have a telehealth clinic that supports people throughout Australia. So that's a little bit about me. I guess I would have worked with, I think that the last time I tried to count it up over the years, well over 700 people with autism and a disability, providing therapy over the 25 years that I've been in the sector. So been at it for a while. I know it's hard to tell, but it's sometimes you're giving your age away when you start to talk about how long you've worked in the sector. So let's talk about autism. I wanted to start with just a quick history because I think it's important to understand how the diagnosis of autism has developed. The first time autism was used in a clinical term or at all was in the early 1900s, and it was referring to relating to schizophrenia. So the term childhood schizophrenia was often used to describe what we now know as autism. And it sounds a little strange, but when you look at autism at the more severe side of functioning, you could see how back in the 1900s they saw it as schizophrenia, the non-verbal, they're being in their own world. And that's really the first time it was referred to. Then in World War II, Leo Kanner talked about a group of children that he saw as aloof and had difficulty with language. And he termed the phrase Kanner's syndrome. At the very same time, in another part of the world, in Austria actually, Hans Asperger's also was starting to do research on a group of children that again seemed aloof, but he talked about his participants when he was doing his research as having developed language normally. And he termed the phrase Asperger's. Now this occurred during World War II, so there wasn't a lot of communication. They didn't obviously have internet and digital communication or even mobile phones, obviously, as we know now. So what actually happened during World War II was we had these two researchers that were actually describing what we now know as the same diagnosis of autism. And one had called it Kanner's syndrome and the other had called it Asperger's. So we came out of the war and of course they realized we're actually talking about the same thing, but I don't know whether that had much to do with the fact that they both put their name against the diagnosis that they supposedly founded, but they decided that we now had two groups. And that's essentially why up until recently we had autism and we had Asperger's, because there was some confusion about what the difference was. So they decided that they would call Asperger's would be high functioning autism, and Asperger's became the diagnosis that we would give where a child had developed language at a so-called normal, developed neurotypical level and had good verbal communication. So that's why we had both autism. Kanner's developed into the autism phrase, and Asperger's. Anyone familiar with Lorna Wing's work in the 1970s, she then developed it into what we now know as the spectrum, and it became autism spectrum disorder. So certainly many of the children that we diagnose now with autism would not have been diagnosed with Kanner's syndrome. The diagnosis has broadened dramatically since the first days of Kanner's syndrome and even the Asperger's described by Hans Asperger's. So then it landed into what we call the DSM-5. So the DSM-5 being the book we use to diagnose mental health conditions. So the only place we can go as diagnosticians is to go to this book. So it's called the Diagnostic and Statistical Manual of Mental Disorders. A horrible name. And also there is some discussion about having autism in this book as a mental disorder, and I completely understand that, but this is the only place that we can go to look at, can I diagnose this child or this adult? We can diagnose adults. Can I diagnose them comes from this book. And the way that we diagnose autism is we look for the presence or absence of a set of behavioural symptoms. So we're looking, there's a list of symptoms, and I'm going to put it up in a second. Please don't, it is not about whether you can actually read it, because it's only 1/3 of the diagnostic criteria, but I'm really trying to illustrate our point here. We need to be able to read through this and make a subjective/objective opinion when we read this about whether the person in front of us that we're diagnosing meets these criteria or not. So and that's what the book describes to us. So you'll see here on the left, I have the part of the diagnostic criteria for autism spectrum disorder. So I need to decide, does this person have problems with social approach? Do they have unusual social initiations or use of others as tools? And this is literally the way it's worded. So you can see how there can be a level of interpretation around when we diagnose autism. Let me give a comparison. If I fall over and I can't stand up again, my leg, I'm in pain, so I'm crying, I'm grabbing at my leg, and I'm keeled over in pain, and I've got hold of my leg and I'm screaming and I'm crying. You would look at me and think, I think there's something wrong with her leg. So based on my behavioural symptoms of crying, screaming, holding my leg, we're making an opinion or an assumption that something's wrong with my leg. So off we go to the hospital, and the doctor maybe looks at my leg and examines it and makes the same assumptions based on what he can feel and my reaction to him touching my leg or trying to move my leg. So again, behavioural symptoms based on what I'm doing and how I'm behaving. Then he goes to a more objective test, and the test is usually an X-ray. I'm not a doctor, but I'm pretty sure it's an X-ray, and takes pictures of my bone. And then he can see from those pictures and diagnose a broken bone, hence a broken leg or a fracture in my leg. So what he's able to do is grab a test, take a picture, and get an outline of, is this a broken leg or not? And there's literally a picture in front of him that tells him that. We cannot do that with autism. And in fact, we can't do that there's very few mental conditions that we can actually do that with. So there's only a handful from what I can think at the moment. So the diagnosis of autism can have quite a large subjectivity to it, in that the person doing the diagnosis needs to be able to interpret these criteria and decide what a lack or a failure to make eye contact actually means. And for some people, that can be never making eye contact. And I have certainly worked with some people who have diagnosed autism over the years because a child doesn't make eye contact. And that's not the only diagnostic criteria. In fact, it's not one of the big diagnostic criteria, but it tends to be the one that most people know about. So what we need to do when we're diagnosing autism is interpret the symptoms in the book, but also have a really good understanding of what autism looks like and how it presents in children of different ages, and also in boys versus girls. So there's also a real need for the person doing the diagnosis to have an understanding of what we would call neurotypical child development, which is how much do we expect a 3-year-old to be using eye contact? How much do we expect a 3-year-old to understand social initiations? How much do we understand a 3-year-old to be able to share? Because we need to first be able to say what is normal development or neurotypical development, and then if this child is outside of what we consider neurotypical development, is it in the area of autism, or is it just a little bit outside and maybe they're just a little behind in their milestones? So it's not as easy as getting a picture, and it's not as easy as what I call an eyeball assessment. So I find it very rare that I've been able to diagnose autism by just talking to families and watching a child. I personally like to have the use of a standardized assessment tool with that consultation with the family and those observations and the interpretation of the book and an understanding of child development. So autism is diagnosed, however, by some very 3 key areas. So we won't diagnose or shouldn't diagnose autism unless there are problems in social communication. So social communication, however, is very different from factual communication. And if anyone's familiar with Temple Grandin, she really describes this well in her experience of having autism, in that someone on the spectrum may find it easy to have a conversation about how a computer works, because that's not about social communication, that's knowledge, that's factual communication. However, the general conversation that other people might take for granted of, hey, how was your weekend? What did you get up to? That's considered that social communication, and that's where we tend to see the deficits in people with autism. The other areas is where we see problems in that social interaction. So the very early part of that is turn taking, and it's why therapists work so intensely on things like sharing and turn taking at the really young ages that we see children coming into the clinic, because it's such a foundational skill for all social interactions and how we interact with others. So we see that people on the spectrum have problems in this more social interaction, and certainly often and I don't like to generalize when I talk about autism. You know, when you've met one person with autism, you've met one person with autism. Everybody's different. But when we do talk in generalizations, there's often difficulty interpreting, you know, body language and gestures and facial communication. So when we are talking to someone, you can often tell when they're maybe bored or maybe a little bit annoyed. It's common for some people on the spectrum to have, or common for most people on the spectrum to have difficulty with that, and for some people not to be able to pick up those interpretations at all. And also, as many of you will know, there's the restricted repetitive patterns of behaviour, interests or activities. So they can range from things like hand flapping, rocking, to you know, having a particular focus or special area of interest, you know, Thomas the Tank Engine, horses, and we see a whole variety in our clinic of what those interests and activities can be. So as I mentioned earlier, it's a spectrum disorder. And this is a really important point in that why we see that people on the spectrum present so differently. And also goes back to my earlier point about that diagnosis, why it is really important to get diagnosed by someone who has a really good understanding of autism and neurotypical child development, because there is such a spectrum on this. And just to give you an example, if we've got one end of the spectrum being mild, or what would now be referred to as level 1, we have now changed the book. By the way, the Diagnostic and Statistical Manual, a lot of people have been asked and coming to our clinic now going, like, you know, I got a diagnosis of autism or Asperger's X amount of years ago, 4 or 5 years ago. Now they're wanting to know what level I am. Well, we didn't have the levels in the Diagnostic and Statistical Manual of Mental Disorders version 4. So we didn't give people a diagnosis as autism level 1, 2 or 3. But now that they decided to put that in based on research, and they've removed Asperger's, by the way, we cannot diagnose Asperger's anymore. It's no longer in the book. Those people will now be captured by the autism level 1. A lot of controversy about that, and I completely understand that. But unfortunately, when they change the book, that's why you'll see so many changes in diagnosis. Another big one I get asked about is ADHD. What's the difference between ADHD, attention deficit hyperactivity disorder, and ADD? Well, the difference is we changed the name in the book. So if you were diagnosed with ADD 10 years ago, you'd now be diagnosed with ADHD. We just changed the name. But anyway, going back to a spectrum disorder, if we look at the mild range, which we would refer to as level 1, and the severe range as level 3, we've got the SC is the social communication deficit or problem, and the social interaction, SI, and the repetitive behavioural interests. So we could have a person with autism have very mild difficulties in the social communication. So they're able to communicate, they're verbal, they're able to have a social communication, or maybe they're at a party and they're able to have that discussion with people. They might seem a little bit awkward, but otherwise able to have those social communication discussions. Whereas the one on the bottom is the social communication is more the severe range. So this person could be nonverbal, or they could be verbal but not engage in social communication, like to talk facts and knowledge all the time. And then the social interaction, we could be more on the mild range. Again, someone who might seem a little awkward at parties, but is able to fit in and maybe imitate what they need to do, or have learnt how they need to act at a party and how they communicate with other people, might be able to pick up body language and interpret people's facial expressions reasonably well. And then someone who's maybe on the severe side of that social interaction is not able to do that at all, and might be in their own world and more focused on what they're doing and not really interpreting anything that's happening in the environment around them. And then we might have repetitive behavioural interests. So we could have someone who's at the party, can have social communication a little awkwardly, not great at reading people's body language, but still able to interact with others, who might have a very strong, severe repetitive behavioural interests. Let's say it's computers. And they're very fixated on computers. They'll talk about computers for a long time. They know everything about computers. And then you might have someone who on the bottom level there, their repetitive behavioural interest is again severe, but not as severe in that. And they may have an interest in, they might be hand flapping or movement repetitive behaviours. The top one, by the way, in the blue circles is probably where we would put someone like Bill Gates. So Bill Gates has now come out and said that he believes he's on the spectrum, and I've never met him, but he probably is. And when I describe someone at a party, that's how people have tended to describe. In fact, I had someone in one of these trainings whose husband worked with him. So that's exactly what he's like at parties. And if you Google Bill Gates, he actually has his entire house set up so that when he walks into a room, the lighting changes, the temperature changes to his preferred level. And I believe he used to have it set up for his wife, but I have heard they're not together anymore. But because he understands how important it is to have that sensory environment at exactly the right input for him to be able to function. And I'll talk a little bit about sensory in a minute, about how important that is. But I think this illustrates hopefully well that it's a spectrum disorder. So that's why we see such a big difference. And again, illustrates the challenges in diagnosing unless you really understand autism and are able to understand neurotypical child development. Let's have a look at who can diagnose, because not everyone is able to diagnose autism. There's been some criteria come out very recently suggesting who can. A paediatrician can absolutely diagnose autism. I actually really like to have a paediatrician involved. We're a multidisciplinary team of therapists, so we don't need a paediatrician to sign off on our diagnosis. However, I do like them to be involved, and usually we do get them to sign as well in agreement of the diagnosis. A multidisciplinary team, so that's a psychologist with a speech or an OT, are able to diagnose autism, and a clinical psychologist can diagnose autism as well. If you're getting the diagnosis to receive something like a government benefit, like the disability pension, it has to be a clinical psychologist. That's come out very recently via the government. I have no understanding of why, to the point that I know some people have gone to a psych that specialises in autism and has for many, many years, who have then needed to get a clinical psych who's straight out of uni, who's never met a person with autism, sign off on the diagnosis. But it's just, I think it has a lot to do with the understanding of how they classify and identify people for government benefits. And it's very much linked to what we call the ICD-10, which is another classification system that clinical psychs do a lot of work in. So a paediatrician, a multidisciplinary team of therapists, and a clinical psychologist tend to be the people that can diagnose autism. These are the questions that I would be asking if it was someone in my family. And I believe everybody has the right to be able to ask these questions. I'm the kind of person that when we moved, I went and met the local doctor, and she said, "Why are you here?" I said, "I'm here to meet you because I want to know who you are, if I'm going to bring my family to you and entrust our health with you." I think I've been the first person that had ever done that with her. I believe you should do that with a therapist. And I think you have a right with your family members to ask these questions of any therapist that you're going to see. You're entrusting them and their skills with some of your most precious possessions, your family. So how many people with autism have they worked with and diagnosed? And what is their understanding of typical child development and milestones? So I think getting an understanding of their knowledge in those areas. Probably another one I would throw in is who oversees their work and supervises them, and what skills do they have in autism and child development, because all psychologists are supervised, and that person usually has an oversight over the other psychologist's work. So there would be a level of how good they understand the diagnostic criteria and how it works in practice with actual children and people is really important. So those would be the main questions that I would be looking at if it was anyone in my family. There's standardised assessment tools. We should never use them alone because of that initial PowerPoint I showed with all of the diagnostic criteria. The best one is called the Autism Diagnostic Observation Schedule. And if you've ever seen it in action, we actually play games, things like sharing games and communication games, social communication, to get an idea of the child's ability to do that in an environment that's been set up to hopefully bring out the best in them. Do they have the network or professional support to rule out other conditions? this is one of the main reasons that I started a multidisciplinary team. I worked as a sole psychologist for many years. And as a psychologist, we're trained in psychology. And there's some things that we don't have as good an understanding in. So a perfect example is, as a psychologist, I have quite a good understanding around attention deficit hyperactivity disorder. What I don't have any training or any knowledge about as a psychologist is sensory processing. And I believe it's possible I wrongly diagnosed people with ADHD because they ticked all of my boxes as a psychologist for ADHD. However, they probably would have more aligned with a diagnosis of sensory processing. But because I didn't know about sensory processing, it's not in that diagnostic and statistical manual mental disorder books, but it's very much a real condition. And anyone who has a family member or knows anyone with autism will know what I'm talking about with sensory processing. So it very commonly gets misdiagnosed as ADHD. There's also a number of syndromes that very commonly get misdiagnosed for autism or vice versa. So it's really important to be able to look at that bigger picture and have an understanding of what is commonly misdiagnosed and what do I need to rule out as well with autism and some of these other conditions. So it's important that the person doing the diagnosis has an understanding of those as well. All right, I love this video. I am going to play a video for you. If you have anyone in the room with you who has autism or you are on the spectrum yourself, you may choose to not watch this now and just mute my sound so that you can't hear the video. It can trigger off meltdown, as we're going to talk about a bit later. It's best watched in the dark, but if you'd like to turn your light out, please go ahead. But I will give you a handout after the presentation so you can go and watch it again. It's freely available on YouTube, but it's one of the best that I've found. So I'm going to put this on now, and yeah, so if anyone needs to turn the sound down, do it now. You'll see me change the slide and you can absolutely put your sound back up then.
Right now, as you sit in this room, it's very easy for you to focus on my voice and understand every word that I'm saying. For you, it's the only noise in the room. This is not how children with autism hear. They hear everything. Sounds that you may not even notice they hear. And they hear them all at the same volume. So as you listen to and are able to focus on my voice, they hear the fan blowing. They hear doors closing. They hear the wait staff clearing tables. They hear the woman 10 feet away rummaging through her purse. They hear a fire truck outside. They hear people walking to their seats. They hear someone pouring a glass of water. They hear the wind. They hear a car alarm going on. They hear someone coughing. They hear a cell phone ringing. They hear a baby crying. If this is what your world sounded like every minute of every day, what would you do to cope? Would you run? Would you scream? Would you rock back and forth? Would you fight to get away? Would you jump up and down and flap your hands? Would you bite your cheek into a blood? Would you hit yourself in the head? What would you do to make it stop? What would you do to make it stop? Our kids are always doing the best that they can, always, to cope with a world that they simply don't hear the same way that we do.
I think that's a good example of what it can be like for some people with autism. I'm not saying that everybody on the spectrum experiences every environment that way, but if I experienced one environment like that once a week, I think I would struggle just not being able to filter out some of those noises. And I'll talk to you about why that is. There's something called the reticulator activating system in our brain that allows us to filter things out. And we believe that for some people on the spectrum, they're not able to do that, whether it's visually, whether it's auditory or gustatory, so in your stomach and your intestine tract, all through the senses. We believe that that can be one of the reasons why we see so many meltdowns, and I'll talk to you a little bit about meltdowns. I'll very quickly go through this. Autism is definitely on the rise. It's increasing. We're now looking at 1 child in every 70 diagnosed with autism in Australia. Worldwide, it's about 1 child in every 160. However, those figures will differ obviously between countries and how they diagnose and how good they are at diagnosing. It's 4 times more likely in boys than girls. Look, we're definitely better at diagnosing autism in boys than we are in girls. Girls do present or can present quite differently. Girls get very good at learning, learning social skills. And it's one of the ways that Temple Grandin says that they did well in the 1950s when she was a child, is that her mum taught her social skills the same way that anyone, if you're a similar age to me, learnt the timetables. 1 is 1, 1, 2 is 2, and learnt social skills. Put your hand out, shake someone's hand, say, hello, sir, how are you? In sort of that rote learn fashion. We don't tend to do it like that anymore, although we certainly have learnt that that is one of the ways. I think we do it a bit more sophisticated now in teaching those social skills and social interactions, but girls tend to pick that up and mimic the other girls around them. So sometimes we miss the autism diagnosis because the person diagnosing is actually looking for these massive gaps in social interaction and social communication, but girls can get really good at mimicking those. One of the other reasons that people often get not diagnosed when they do have autism is somebody who isn't familiar with the diagnosis and diagnosing it will say, well, they're actually okay at school, but when you talk to mum's saying actually when they get home, it's a massive meltdown and, you know, they can't keep it together. And we taught as psychologists, if something doesn't occur across all environments, if a behaviour doesn't occur across all environments, it's probably not a diagnosis. In many cases, that's not the case with autism. Many of you out there as parents of a child with autism will understand that often these children are able to contain themselves in certain environments, but once in a familiar environment or with the security of mum around or dad, can't hold it in any longer. So that's another thing that we see with girls and boys to some degree, but also mainly with girls. Why are rates rising? We've changed the way we diagnose. So we've taken Asperger's out, we've taken pervasive developmental disorder out, we can't diagnose them anymore. We've made it into a spectrum. So one of the reasons is that we've actually just changed the diagnosis. There's definitely a better recognition and awareness of autism now amongst healthcare professionals. And I think to some degrees amongst childcare workers and teachers as well. So it's probably getting identified for at least review more than it would have. We've also found that the diagnosis of intellectual disability is decreasing at a similar correlated rate to the increase of autism. So we're pretty certain that because of that lack of awareness of autism, some people who maybe should have been diagnosed with autism were diagnosed with an intellectual disability instead because the person doing the diagnosis understood that better. There's also some biological factors. We know that it's more likely in older parents and premature birth. So we're seeing that happen a little bit more. So they're the main reasons why we're seeing the rates rise. So let's have a little bit of a chat about social communication. So we've got those 3 areas that we do see the problems in and have to be able to see them to be able to diagnose autism. And I'm not going to go through what these mean directly, but give you some insight into what we see and also what we understand about it. Social communication is not necessarily a factor of the person not understanding language or not being able to communicate. I have certainly had, and it's only a handful of cases, but had a handful of clients who were nonverbal for years, many years, most of their childhood. And one of these people that I'm thinking of was about 28, the other one was 14. So I was providing therapy through nonverbal means, and they were labelled as nonverbal in their files, but there were very small instances. In one case, a young girl spoke directly to the police for 4 hours, relaying an incident that she had been involved in, even though prior to that time there was no record of her ever having verbal communication. So what that spells out is there are some people on the spectrum who they are non-verbal because what we believe is there's no strong social motivator to use language to communicate. There's probably some other layers to that. Certainly, Temple Grandin talks about how she thinks in pictures, and it took her a long time to understand what certain sounds, as in language, meant. There's another one called Lucy. Lucy is an Australian with autism. She wrote a book called Lucy's Story, and she talks about how it took till she was about 4 or 5 to understand that when someone said Lucy, they're actually talking about her as a person. So there's this lack of understanding at times that language or that complexity of sounds actually means this, and then often when people do understand that, they can not really see the need to have some of those communications. That is not every person with autism, but it is certainly how some people will describe it. I have a colleague who is on the spectrum, and he always says, I would be taught to say, hi, Amanda, how are you? But in all honesty, I don't understand why you guys do it. It doesn't really interest me at all. I'd much rather talk about the computers that I'm working on. But he's learned that he has to do that, even though he gets nothing back from it, as you and I might do. He'd get a lot more back if I sat and talked to him about my computer monitor or how my computer operates. So there's not always a skill or a language deficit. In some cases there is, but not always. Difficulty communicating for social purposes. So again, we see a lot of people that can stand up and lecture about a specific topic or talk on a specific topic, but it's those social interactions that they struggle with, and have difficulty initiating and maintaining conversations, that social skill of starting up a conversation. And then, of course, people who are non-verbal. When we look at the social interaction, it can be real difficult to read facial expressions. And I've got a really good activity in a minute to show you why that is. But also understanding social situations, that we need to adapt our language or our body language or how we interact with people in different environments. If you think about, when you go out for dinner with a group of friends, as opposed to sitting in a workplace function and having a formal meeting, we do behave differently, we sit differently, we communicate differently, and understanding those intricacies of social environments and social cues can be very difficult for people with autism. We don't know whether it's a chicken or an egg thing with social communication and social interaction. So is it that my social communication doesn't develop, or I have difficulties in that because I don't understand social interaction as well, or is it the other way around? But they're definitely linked. And this is where the eye contact comes into play. You can absolutely have autism and engage in good eye contact. It is one of the things that we work on in early intervention. It used to be one of the main things, decades ago. It's certainly not as much now, but as a social cue and social interaction, it's something that we develop. And often we will see children come into our clinics who have had therapy before, but haven't been diagnosed autism. And because they've worked on eye contact, we're seeing none of those kind of behavioural symptoms, and we have to dig back and talk to parents that, well, actually we've done a lot of therapy in those areas, because early intervention works pretty much. Okay, facial expressions. So when you look at these pictures of people, they're all smiling. So we all make an assumption that they're happy. Their smiles are different. So the gentleman with the beard, we can't really see his teeth, but some of these people, we can see their teeth very clearly. You'll also notice that they have different skin tones. They have different hair colour. They have, this lady here has dimples. They have different haircuts. There's nobody there with glasses, but often people have glasses on. The one gentleman has a beard, he's got hair on his face, but none on his head. So they all look very different. We filter out all of the differences. This is that reticulator activating system. I'm not saying we don't see it, because when I point it out, it's very obvious. And if someone said, what are the differences, you could very easily pick it up. However, we filter it out when we're figuring out how do these people feel, or what emotion are they displaying. And we see the smiles, we see their eyes are often more narrowed with the smile, and we have learned very quickly at an early age that that means they're happy. Remember the video where the person with autism may not be able to filter out all of those pieces of information. And sometimes what people on the spectrum have difficulty doing is filtering out the fact that every one of those people looks different. A smile on each of those looks very, very different. So instead of quickly looking at those pictures and saying, oh, that person's happy, they're looking at and processing, whether consciously or subconsciously, all of those differences and trying to figure out what is what here. So this is why often people on the spectrum have trouble reading those social cues, because everybody looks different. A smile on one person looks very different to a smile on another person. It doesn't on Thomas the Tank Engine. Whether it's Percy or Thomas or the other ones that I can't quite remember the names of at the moment, I'm sure some of you will know, the smile looks the same because the face is the same. So the Thomas the Tank Engine characters, there's no need to have to filter out the other facial features. I can understand that that is a smile on the Thomas the Tank. All I have to filter out is the colour of the caboose, mostly. There's very little else that changes. So when you think that people with autism may have difficulty filtering out those input, it makes sense to understand why we have so many young boys that really love Thomas the Tank. And that friend I told you about, who's doing finished a double degree in computer engineering, still to this day, if there's a new Thomas the Tank Engine, has to buy it and put it in his wardrobe. It's a real fixation, and we believe that it might stem from the fact that this is predictable. This is certainty. I can understand what's happening when I just watch the show and I can enjoy it. I think it also helps that it's about trains as well. Repetitive interests. Sometimes when they're often age inappropriate, that's why it's easy to pick them up, hence the Thomas the Tank Engine with a male who's 18. It's harder to pick up when those repetitive interests are more age appropriate. So one of the common ones that we see in adolescent girls on the spectrum is horses. I am not saying that if you're interested in horses, that's the diagnostic criteria by no stretch of the imagination. However, it is one of the things, and because it's so appropriate for adolescent girls and to be interested in horses and quite fixated in horses, someone who doesn't really understand autism in girls would then say they don't have any restricted repetitive interests and possibly rule out autism. The thing to know about repetitive interests is they can often be stemmed from anxiety, and if you try to remove them or change them, the person's anxiety, distress or agitation can increase dramatically. So it's really important that when we're working with, we've had some very, I guess, socially inappropriate repetitive interests that we have to adjust. And it's important that you do those very slowly, gradually, but in a very structured manner. And we often use a way of helping the person understand distress, anxiety, or agitation as we do that, similar to how we work with anxiety and relaxation, I guess. Excuse me. I saw one of the questions, what's the difference between sensory processing and ADHD? This might answer that question. When we watched that video, some of you might have gone into sensory overload. The only way that I can relate to sensory overload is, and for me, this is what sensory overload is. I'm at home, my 21-year-old son's got some music pounding out of his bedroom with the bass up really high. My 13-year-old daughter's got Mario Kart on the TV making all this bing, 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 bing noises, and I got this loud bass coming out of the room. My husband's downstairs drilling into something, and then my mobile phone's ringing while I'm on my emails. That's my sensory overload. That's the point where I just want to do this and just tell everybody to turn everything off. It's too much. Because my senses are heightened, my brain and my nervous system are just bombarded with too much information. And for me, it's an auditory information. I can usually deal with visual, but not auditory. And that's what sensory overload is. I think we all experience it to some degree, but in different ways. I can only assume that for people with sensory processing difficulties and on the spectrum, it's probably experienced a lot more heightened than certainly what I do. Any of these senses can have sensory overload. So visual, auditory, smell, gustatory, taste, proprioceptive, interoceptive. I'm not an occupational therapist. This is very much an OT's area, and vestibular, but things about your ability to balance and your relationship to your body in space and where your hand is in relation to your body. All of those things use our sensory system. I did not know what occupational therapists were until I've been working with people with autism for a few years. I think a good occupational therapist is something that most children on the spectrum in early intervention really need to access quite quickly, because they work very practically and really well with some of these sensory issues and some of the other issues that go along with autism. Okay, let's talk about meltdowns and tantrums. If you've ever been with someone who's had a meltdown, this description probably matches. The core of a nuclear reactor melts and releases radiation, a very fast collapse or failure, or a very fast loss of emotional self-control. Whereas a tantrum, we've all seen tantrums, an uncontrolled outburst of anger. So you might see crying, screaming, stiffening, kicking, vomiting. We have kids holding their breath, all kinds of things, running away when they have a tantrum. They often both look very similar. A meltdown is about that sensory overload. It's about that sensory brain and nervous system having too much stimulation, and I just feel overwhelmed and I just don't know how to make it stop, and it just has to stop. So when a child is having a meltdown, they tend to lose control. They're not in control of how they're behaving. They're just reacting to that overload of sensory stimulation. They're overwhelmed. They just want it to stop. They don't have a plan. We often see, not often, but sometimes children can injure themselves in meltdown. They actually don't mean to. So the difference between this and a tantrum is where a child will actually be in control of what they're doing. So when a child's having a tantrum, we'll sometimes see them go over to the wall, look over at mum and dad, make sure you're looking, and then go bang and put their head on the wall. Whereas a child in a meltdown will not do that. They'll run straight into the wall. They'll just be trying to make all of this sensory input stop. When they're having a meltdown, they're not aware of how their behaviour is affecting you or impacting on anyone else in the environment. So talking about how it's hurting other people or what other people can see is not going to help during a meltdown. You can have that conversation over and over again with someone in meltdown. It will not change the next meltdown happening because they just can't control it. It's too much overload. So it can be sensory overload. It can be too much information, emotions taking over, too heightened, too many demands. We've all felt that at times, you know, where you just feel like I've got too much to do and everybody wants me to do something different. Too much unpredictability, fear of what could happen. When you think about not being able to read people's facial expressions, the world's a very unpredictable place when you can't at least gauge a little bit how someone is going to react to you or feels at the moment that you walk up to them. So for people with autism, sometimes just having a person near you can be very unpredictable and have a lot of uncertainty about it. And any of those can cause a meltdown. How do we prevent meltdowns? It's about reducing the stimulation in the environment, and a good OT will be able to identify what a person's sensory profile looks like and identify there are some things that when a child's having sensory processing concerns that you actually need to increase their sensory input in some areas. And we often find when children come to the clinic, somebody prior to us, not, you know, mum and dad, just out of what we think is best, is decreasing those sensory inputs that need to be increased. Excuse me. And just remembering that emotional overload is also a stimulation. When a child's having or someone's having a meltdown, you really need to reduce demands. Now is not the time to be teaching them, you shouldn't do this, this behaviour is wrong, you're not going to get what you want, because that's not what it's about. So reduce the noise, reduce demands on them, more be looking for reassurance, calming the environment down, reducing the noise. Find the reset button. We all have a reset button after a hard day, something that we like to do that just helps us calm down. Get to know your child or family member's reset button and help them use it. And if you don't know what it is, start looking for it, or you can even teach them a good reset, appropriate reset button or calming strategies. Really, really important. Safety is important in a meltdown. Remember, they're not in control. So this is often where a child might run out in front of a car. They're not meaning to do it. They're just trying to escape. Make them feel safe and secure and stay calm. As I said, reduce the sensory stimuli. If you can carry anything that helps with sensory preference toys, massage balls, body socks, weighted blankets, they can all be extremely useful. They can also do the opposite if they're not prescribed properly. And also try to explain very calmly and with as little words as possible, you know, things like what you need to do and what you'd like them to do. A tantrum is a behaviour that has a purpose. I want something, I want to avoid something, I want your attention, or I've learned that this is a really good way to get whatever I want. So this is common in the 2 and 3-year-olds, and it's very unlikely to occur when the child is alone. However, a child can have a meltdown when there's nobody around. The child is in control when they have a tantrum, very much so. However, a tantrum can then flip into a meltdown for some children on the spectrum because, of course, they're screaming, they're yelling, they're using tantrum behaviours to get what they want. And by doing that, they then increase their own sensory overload and flick into a meltdown. So that's one of the difficulties, is one can lead into the other. A meltdown will not lead into a tantrum. So when you're looking at tantrum behaviours, start to look at what happened before and what happened afterwards. And they'll give you a little bit of an idea of what did the child use the behaviour for, or when is it most likely? So it's most likely when we go to the shopping centre and we pass the chocolate aisle. Okay, so the tantrum is about getting a chocolate. What happens afterwards? Mummy gives in because everyone's looking at me and I've had a really frustrating and difficult day and I just want this to be over. Aha, the tantrums in order to get a chocolate, and guess what? It works. So this is what we do as in behaviour support. This is our very first basic step that we talk to families and carers about, is what happens before and what happens after a behaviour. You'd be surprised you start to see this pattern emerging. I've gone through that. I'm just well aware of the time. Try to keep calm during both, and I know that's a lot easier said than done at times, and I think it's about focusing on what outcome you want to achieve. You want the tantrum to stop, or you want the meltdown to stop for the child as well as you. So how do I make that happen? And the most important way is to say calm yourself. And I know as a parent that's not the easiest thing to do. Recognise your own feelings, and you know, we get frustrated. We're only human as well. The more we can take a big deep breath and just calm down. If you're able to play tag team with another parent or somebody, that can be really helpful as well when you've just had too much. And tantrums can go on for a long time. Ensure your communication and behaviours match the outcome that you want to achieve. So kids will very quickly pick up, it's called attunement, on how you're feeling. If you're feeling anxious and they're having a meltdown, they'll actually pick up on that anxiety, and that anxiety will then feed into their meltdown as well. The same thing happens with a child who suffers from anxiety. If you're anxious, they'll notice you're anxious, and that just reinforces there's something to be anxious about here, because I know mum is, and that'll happen subconsciously. It will end. It's just a matter of when. So it's really important to try to keep calm and manage your own emotions. Ignoring a tantrum can work well, but make sure the child isn't going to escalate to a point where it's unsafe. They can't die from holding their breath, but they can pass out and start breathing again. And I know a lot of times we have toddlers doing that holding breath. Give the child some space if you can, if they're having a tantrum, you know, and explain to them, just going to give you a minute. I talked about that we're not getting a chocolate. Let me know when you've calmed down, and just ignore the behaviour. So ignore the screaming and the yelling. There's a difference between ignoring the behaviour and ignoring the child completely. So once they start to de-escalate or give little signs of not screaming, that's when we're reinforcing. Try not to give in to a tantrum. You actually just end up reinforcing that, guess what, it works, I'm going to use it again. And I know there's, you know, I can say as a psychologist, have I ever given in to my children's tantrums? Absolutely, because I'm only human. But the more you do that, the more the behaviour will become learnt and will continue. So when you do give in to a tantrum and you do end up giving that chocolate or whatever it is, spend some time afterwards thinking about what can I do next time so that I don't have to do that. Usually the answer is, how can I pre-plan? What can I do before that's likely to happen to set up the chance that the child understands the tantrum's not going to work and there's a reward at the end if I don't have a tantrum. Set up some clear expectations so that your child can understand we're going to the shops, we're not buying a chocolate. If you come home and you don't scream and you don't yell and you don't ask for a chocolate, then when we come home, we'll do X or Y, or I'll give you X or Y. So setting up that reward that you can use throughout the shopping or the environment where you think the tantrum's more likely to happen. Look, I won't go into cognitive thinking too much, but it's worth understanding that in autism, we can see a very strong black and white thinking to its nth degree. For example, chairs are for sitting on. If someone stands on a chair, It's just so unpredicted to me. It really upsets me because I don't understand why would you stand on a chair, chairs are for sitting on. That kind of very black and white understanding of the world and rigidity of thought. It can be really difficult for people with autism to see other people's perspectives. It's called a theory of mind deficit. It doesn't really kick in until about, I think it's 10 years of age, where so even children under 10 years of age, it's very difficult to be talking to them about when you hit your brother, do you know how he felt? Because that's a very high level cognitive thinking. So young children, I've seen people talking to 2 and 3 year olds about, now when you did that, how do you think that person felt? They actually can't understand it. So just be really aware of using that, particularly with children on the spectrum. Some children will understand it on the spectrum as they're older, but if you're finding that those kind of strategies aren't working, we need to go back and start teaching theory of mind, which is the ability to put yourself in someone else's shoes and understand their point of view. Most of you will be aware of using visuals. Again, Temple Grandin talks about, she actually doesn't think in words, she thinks in pictures. That blows my mind, how someone would not think in words at all, particularly someone with 2 PhDs in agricultural areas who's designed numerous things in the agricultural world that are used globally. She thinks in pictures. So that's where we see a lot of these visuals, and when we do therapy and support children with autism to learn new social skills, it's very much about making everything concrete. Emotions are very abstract, so we have to bring them down to a very concrete level rather than talking about happy, sad, angry, agitated, frustrated. We need to bring them down to something that's more concrete to start with. It might be a colour, might be relating them to colours, it might be relating them to objects or something that they can understand, and then starting to label them and then making sure that association happens. I talked about your reset button. Everybody needs a reset button. What do they use to keep you cool or to calm down? There's no different for people with autism. That's one of the first things that we work on with anyone that comes into our clinic. And setting up an environment to stay calm. And often for people on the spectrum, that's that certainty. You know, the world's very unpredictable when you can't read people's emotions and gestures and body language. So that routines and those clear expectations can be really helpful at those times. Strategies can wear out. What worked for you 5 months ago might not work now. And I know that's not extremely helpful. And it just means we have to continuously be creative and adapt some of the strategies that you're using. So it may be strategies you've been using up until a certain point worked well, but now they're not. And it just might mean it's time to adapt those strategies a little bit, maybe change the reset button, look more at the environment and try to just trial little changes and see if they work. And of course, some strategies will work for some children or people and not for others. So it's not a one size fits all by any stretch of the imagination. And that I find that really frustrating when people think that this is a person with autism, so we use this strategy and it's going to work, because that's definitely not my experience. It's about having that understanding of the person and then having an understanding of what tools can work for people with autism. There can be a vast array of those tools. Every single one of us is unique. Okay, I think I'm pretty close to time. That's pretty good. So one thing I do want to tell you about before anyone jumps off, but I'm going to get to your questions, I'm happy to talk about them, is we're offering free meet and greets. As I said before, for me, I don't entrust my family's health and well-being with a professional unless I've met them and I've had the chance to ask questions. And that might sound a little bit pedantic, but I believe that's really important. So we give people that opportunity at Real Therapy Solutions to book in with one of our experienced therapists and just ask questions. How many people with autism have you met? You know, do you understand what ADHD and how many kids have you seen with ADHD? Or, you know, this is what my child presents with is this something that you guys can help with? Or, you know, what would sessions look like here at Real Therapists? Any questions you like. If we can't answer them, then we'll go and find the answer for you, or we'll tell you that we don't know. But most of the time, it's just about, you know, getting to know us and finding out if we're right for you. So if you'd like a free meet and greet, give us a call. There'll also be a link in the emails that you have to give us your details, and one of our receptions can give you a call and book that in. They're online at the moment, and often are, but when you can come in and have a look at the clinics as well if you're close to one of the clinics.